Hello, and how are you? My name is Winnie Barawa. Welcome to my session on invasive procedures and tests for respiratory disorders. We've just done on the bit of non-invasive procedures, and if you've not watched that, kindly go ahead and watch it also. It explores procedures that don't need us to explore the tissues or withdraw samples per se. But for invasive procedures, we will look at procedures that will need us to withdraw blood or to access tissues through invasive methods. So if you're new here, this is a channel that looks into lessons and lectures pertaining healthcare. And if you enjoy these classes, remember to subscribe or click on the subscribe button and click on the bell so that you can be notified when our next class is up. So let's focus on today's lesson and what it's all about. So the first procedure that is invasive for respiratory disorders is what we call arterial blood gas, famously known as ABG. So what arterial blood gas test does, it measures the level of oxygen, it takes measurement pertaining to oxygen, carbon dioxide, and the pH values of blood. And so it will provide ways on how we can access or assess the adequacy of ventilation. And in adequacy of ventilation, we determine this via partial pressure of carbon dioxide, what is written like this. And then you can determine this. Also, we can determine what we call oxygenation or level of oxygen in the blood. That is normally indicated as partial pressure of oxygen. So it's written like this. So it will allow us to tell, the level of acidity and alkalinity of our body, what you also call the acid-base status of our body, whether our body is acidic or whether our body is alkaline. So it can determine what we call acidosis or alkalosis. And ABGs will give us various values, it will give us various analyses, and these are the common results that come out from our ABG analysis. So we have the pH, and we know that the normal pH of blood is 7.35 to 7.45. There'll be partial pressure of oxygen, which is valued at 80 to 100 mmHg. Then we have the partial pressure of carbon dioxide, normally evaluated to be normal within 35 to 45 mmHg. Then there's carbonates, the bicarbonates. These are the bases in our blood. And then we have base excess, which is evaluated at these ranges here, -2 to +2. Then we have saturation, oxygen saturation, which we know is measured also by pulse oximeter, which we saw in the non-invasive procedures, and it's evaluated at 94% to 100%. So as you can see, this is a test that is invasive, and for you to generate the results, you will need to take blood samples, which you withdraw using a needle or after taking an injection. So how do the results come and what do these results tell us? So we've said arterial blood gas is going to give us various particulars, and part of these particulars is the blood pH, that is acidity or alkalinity. So the blood pH we know averagely is 7.40, but the range is 7.35 to 7.45. That is the normal blood pH. Same to oxygen pressure, carbon dioxide pressure, bicarbonates, oxygen saturation, base excesses, and all that. But what do all these values mean? When you are doing all these tests and they give you the results and there are changes and they're giving you all this deviation, what will it mean? So for example, the pH will tell us if the patient is going through acidosis or the patient is going through alkalosis. So what you can also call acidemia or alkalemia. But most books just put in mind, they'll normally mention to you either acidosis or alkalosis. Then the partial pressure of oxygen, normally it's going to guide us to tell you how much of our oxygen has dissolved in plasma. That is in terms of now the pressure of oxygen in our blood. How much of this oxygen that we're breathing in has successfully dissolved in plasma. And then in the carbon dioxide, we are looking at how much also of this carbon dioxide is present in our blood. We are not supposed to have a higher percentage of carbon dioxide in blood compared to oxygen. Therefore, it's normally expected that the pressure of oxygen should normally be higher than the pressure of carbon dioxide. Then you have bicarbonates, which are very key in establishing what we call the buffer systems. And bicarbonates will help us in neutralization of acidity if our blood is becoming very acidic, and therefore you want the values of the pH to go down, or to basically not to go down but to neutralize. So we'll use these bicarbonates. But again, we have the oxygen saturation. So oxygen saturation is the percentage of oxygen that has been carried by hemoglobin or has been carried by the red blood cells. And the more saturated the blood is, the better for our body system, because it means there'll be effective gaseous exchange. So we expect this saturation to be at least 95% and above, or all the way to 100. And then we have the other factor here that we call base excess. So base excess evaluates the concentration of bicarbonates, which is normally affected by processes in our body. And processes here, we mostly explore this on the buffer system, where we talk about the bicarbonates carbonic acid buffer system, where we are saying if there's variation in our acidity or alkalinity of our blood system, then the bicarbonates can react with the acids to neutralize. If we have a state where the blood is very alkaline, then the acids or the carbonic acid can react with this base to neutralize. So base excess is said to be more varied at -2 to +2. Anything beyond these values indicates various status. For example, we are told positive value reflect metabolic alkalosis. That is, the more we head towards the positives, maybe the client is recording +3, +4, +5, like that, that indicate metabolic alkalosis. But if we are reporting negative values, that is, the patient is going more onto the negative sides, like -3, -4, -5, and onwards, then you're talking about metabolic acidosis, which means our patient is deteriorating, and so we need to bring up interventions to stabilize this client. So the techniques of handling arterial blood gas basically means, first you need to withdraw blood from an artery, and you can use different artery levels. You can have the radial artery, you can get this from femoral artery, or even brachial artery. But a few risks you need to at least also get to prep up for, like bleeding at the puncture site. So maybe you can have a plaster to just plaster the site to avoid bleeding. There can be bruises, there's lightheadedness in case you withdraw too much blood, and the patient can experience this kind of dizziness. Some hematomas can also come, but it should not be so common unless this client has bleeding issues. Then there's infections if you don't properly take care of the bleeding site. That is, if you are not observing aseptic technique or infection prevention as required. There's also blood flow problems, like formation of small blood clots that can block the blood vessels around that area. So you can check around all these possible risks that you can prepare for. But generally, we just have to withdraw a sample into our test tubes that can be used under the ABG analysis, under the machines. All right, and the second procedure that can be done that is invasive. So here again is C-reactive protein, known as CRPs. So the C-reactive proteins, this is evaluating again in our blood for proteins that will help us determine if our client have infections or not. So the main thing with C-reactive proteins is basically to determine the level of infections in our body system. So a client who has respiratory infections and you do a C-reactive test, it will show high levels of C-reactive proteins. So the higher the C-reactive proteins, the more the probability of infections that are present in this patient. But we are told it keeps falling when the infection is clearing from the body, and therefore falling in of C-reactive proteins levels in our system means there's a change in our infection levels, or rather the patient is improving and the infection is clearing. So it's normally a good marker if you want to check the improvement or the change in management of your patient. If you're introduced maybe antibiotics, you're managing this patient on various management to eliminate infections, then you can use the C-reactive to check if the management is responding or not. So it's a very good marker for checking progress. And then we have this other test that is known as the alpha-1 antitrypsin level test. What alpha-1 antitrypsin test does, it tries to check for the genetic deficiency of antitrypsin. Now, trypsin trypsin enzyme or trypsin is basically used for digestion of proteins in the body. So trypsin, if you review the digestive system, it's found in places where proteins are normally digested, and it's found in dormant state that we call trypsinogen. So if you want to break down proteins into amino acids for the purpose of the absorption, we use, or rather we convert the trypsinogen into trypsin, or into the active phase of trypsin. Now, for us to prevent trypsin from digesting any unwanted proteins or from digesting proteins in the wrong places, we need to have what we call antitrypsin. So the alpha-1 antitrypsin, this is the agent that protects us from getting our muscles digested by these trypsins, from getting other tissues around us from being digested. And what happens is in diseases like emphysema, this is normally what happens. There's destruction of the parenchyma and there's destructions of the membranes and so on. So we use we use this test, the alpha-1 antitrypsin test, to basically determine the disease we call emphysema, which is a common factor in COPD. We're to talk about congestive obstructive pulmonary disease, congestive obstructive pulmonary disease, COPD. So with this done, it means if there is a high alpha-1 antitrypsin levels, it shows that, well, then our patient in this case is safe. But if there are very low levels of antitrypsin in the body, then it shows also the patient is at risk or actually is a good candidate for emphysema disorders. So that's how we evaluate this test. So we do alpha antitrypsin test to determine the prevalence of emphysema or to check the riskness of emphysema levels for the patient. If there are low levels of antitrypsin in the patient, then we say this patient is at risk of developing emphysema. If antitrypsin is totally absent or deficient, then we say this client actually is confirmatory for COPD or emphysema disease. If the patient doesn't have, you can also give replacement. That is, we've done the test and you've discovered our client actually does not have antitrypsin, and therefore you can introduce replacements or you can give supplements if you have to just boost up and treat this COPD disease. And then we have test number 4, that is D-dimer test. So D-dimer test, so it can be done as a rapid test or you can do the normal lab test. So the rapid tests are good because they'll give you very quick results. So like this is the kit, you just get a cart, get the blood sample there, and you do it on the rapid kit and it will give you the results. So what happens is, what does this test do? It's done mostly to indicate any presence of pulmonary embolism or status whereby we have blood clot forming in our pulmonary vessels. So when blood clot are happening, this is a state now where we talk about coagulation, thrombosis, and all that. So if you want to check likelihood of thromboembolism for our pulmonary patients, then we can check if the result is negative or positive. So a negative D-dimer test says that this patient has no thromboembolism happening, or rather we can say they don't have high chances of getting pulmonary embolism. However, you can't use the D-dimer test as the final test for the purpose of determining pulmonary embolism. Why? The D-dimer tests have low specificity, or rather we say it has poor specificity. Therefore, for you, even if you've done the D-dimer and it's saying that the results are positive and you're worried about pulmonary embolism, it is key that you do other tests to help you make a confirmatory diagnosis or to help you make a confirmatory test or to help you determine that this test is true. Otherwise, you can't purely just use the D-dimer test to confirm this a patient has embolism or not. And so this is how we do it. So it gets a sample. So for the rapid test, you can get a part of this sample, or if you can just do a prick and get the blood sample and run it on the rapid test. But why is the D-dimer test done? It can be done in various status. It may not purely be in the respiratory system, but you can also do it in other status. However, for pulmonary cases, you can do it when you're worried about pulmonary embolism. But for other diseases, because this is a test that focuses on coagulation, focuses on thrombosis, then it can be done where there's issues of DVT. If you want to confirm DVT presence, you can do a D-dimer test. Pulmonary embolism, you can also do it. Stroke, DIC, where we talk about disseminated intravascular coagulation disease, can also do it. So what are the normal ranges in case you're not running the rapid test? So we say in values of less than 0.5 or less than 500 nanogram per milliliters, then we say this is normal, it's not a serious blood clot, it's manageable. But where we have elevated ranges of our tests, where we have more than 0.5 or more than 500 nanogram per mils, then you can say this is an elevated case, and so we have to intervene, that is if you have the clotting happening very fast. So indicative of very active blood clots, and you need to introduce management to prevent spreading or continuation of this clot formation. And then we have the test that is famously known as tuberculin skin test. We also call this test the MANTOUX test. So tuberculin skin test is actually the injection of a protein substance under the skin, specifically in the forearm, to help us determine if the patient or the person has been exposed to TB or tuberculosis. So this is a TB test. So what happened is we are testing the reaction to this protein, and so we will intradermally, so it's an intradermal injection. So we'll intradermally introduce PPD. PPD means purified protein derivative. So it's a reagent. So we'll inject it intradermally on the forearm of our patient here, as you can see. And then for the reaction, the patient's skin will form a wheal. Okay, so we will form a wheal here on the skin. And then once this wheel forms, the next bit for us to do is to use the tuberculin skin test ruler. So this is the tuberculin skin test ruler that will measure the wheel diameter to see how long or the length of this diameter. So it will produce for us different lengths, or it will produce for us different dimensions in millimeters. And these dimensions we will use now to determine if a patient is positive or negative for the TB test. So let's evaluate these dimensions or these measurements. So here are the results. So we are told the results are normally negative for any test that you've done, and then the wheel is less than 5 millimeters. So always anyone who has a wheel of less than 5 millimeters, this is negative. But there are different categories where we can confirm that a client is positive based on this diameter. So for example, if the induration is more than 5 millimeters. So induration is the same as the wheel that we've mentioned before. So if a patient has an induration of more than 5 millimeters, so we are told it is positive, but not always. Reason is we need certain conditions to confirm that this client is actually positive due to. So clients who are immunocompromised, so a client who is immunocompromised, like patient who are on chemotherapy, patient who are on HIV and all that. So immunocompromised patient who give you a wheel of more than 5 millimeters, these are clients who are confirmed as positive. Then we have the second category of TB test who are positive, and that is client who give you a wheel that is 10 millimeters in duration. In this client also have a different category. So 10 millimeters wheel in terms of the size, these are clients who are on IV drug use, children who are under 5-year-old, or people who live in high-risk areas to TB, then you can confirm them to be positive. And the last category is those who are above 15 millimeters in duration. These ones are treated to be positive in any person who has been healthy and the immune system is normal and there's no effects from other things. They are not from high risk and so on. So these ones, you will also treat them as positive. So let's summarize this so that it makes it easy and we don't really dwell much on the notes per se. So let's extrapolate this. So on the positive end, this is what we will get. So we said if the wheal is more than 5 millimeters, the client is positive, but under one condition or under specific condition, the client is immunocompromised. An example, an immunocompromised patient could be HIV patient, patient who has recently contracted an active TB, patient who has nodular or fibrotic changes in the chest X-ray, or a client who has undergone organ transplant. These clients can test positive for TB if they've been exposed and you're worried about their TB positivity. Then we have category 2, those are more than 10 millimeters. So that's the wheal is more than 10 millimeters. The requirement here for you to confirm this client is positive is you check this. That is, have they been recently from a high prevalent country of TB, IV drug users, their employees or residents of high risk settings for TB, their lab personnel who are working on this test all the time, they have other comorbid conditions, their children who are less than 4-year-old, maybe you have infants, children, or adolescents exposed to high risk categories. And the last bit is client who is positive but is recording 15 millimeters of the wheal. So this is for any client who's been okay, there are no risk, there's no immunocompromise, there are no children. So this is a normal person who doesn't have any pre-existing issues. And the normal person who records 15 millimeters of the wheal, this will automatically be treated as a positive case. And this is how you categorize the positivity of the duration in the in the TB patient, or when you are carrying this tuberculin skin test. And so that marks the end of our invasive procedures or test for respiratory diseases. Remember to subscribe, comment, share, and also like our videos. Thank you so much for staying with me all the way to the end, and see you in our next class. Bye-bye.